showed me how to reach for the best of myself. It's all good when you show the way, yeah. 'Cause even if I fall, ooh, I trust you'll stay, yeah, stay. And through the dark and cold, I know it's all good, 'cause now I'm the best of myself. Tried so hard, stumbling in the dark, to learn how to see what you already saw. You're the one to blame for the fact that I can reach for the best of myself. It's all good when you show the way, yeah. Even if I fall, ooh, I trust you'll stay, yeah. And through the dark and cold, I know it's all good. I still wonder how, yeah, you always make it right. And maybe it's all chance, but either way, you showed me how to reach for the best of myself. It's all good when you show the way, yeah. 'Cause even if I fall, ooh, I trust you'll stay, yeah, stay. And through the dark and cold, I know it's all good, 'cause now I'm the best of myself. Yeah. Oh, yeah. Oh, yeah. I have tried so hard, stumbling in the dark, to learn how to see what you already saw. You're the one to blame for the fact that I can reach for the best of myself. It's all good when you show the way, yeah. Even if I fall, ooh, I trust you'll stay, yeah. And through the dark and cold, I know it's all good. I still wonder how, yeah, you always make it right. And maybe it's all chance, but either
Good afternoon, everyone. Thank you for being here with us today for E for Endometriosis free quarterly Zoom session. These sessions are part of our ongoing commitment to raise awareness, empower individuals, and provide reliable knowledge for the endometriosis community. My name is Eve, and I'll be your host for today's session. This session is organized by E for Endometriosis in collaboration with the Pain Clinic. Like many of you here, I have also very painful and heavy flow every month to the point it disrupted my work and social life. It actually took me 4 years to get diagnosed and treated at my 5th year. So I am also an endo warrior, and it's truly a privilege to share this space with all of you today. Today's session will end slightly earlier at 1:25 as Dr. Diana has a scheduled surgery at 2 p.m. Despite this, she still chose to volunteer her time and expertise to be with us today, and we are incredibly grateful. Thank you, Dr. Diana. Before we begin, here are some few important housekeeping guidelines to ensure a smooth and respectful session for everyone. Okay, please switch on your video during the session to promote mutual participation. Stay muted during presentations to avoid interruptions. Remain kind and respectful in your words and actions throughout the session. This talk is intended for general awareness and wellness insights. For personal medical concerns, we encourage you to consult qualified healthcare professionals. This session is also being streamed live on our E for Endometriosis YouTube channel. So if you miss anything or want to revisit today's insight, you can always catch the replay at your convenience. We are also using Pigeonhole Live to make sure your questions can be seen during the live stream. You can scan the QR code displayed on your screen to submit questions anytime. And you're welcome to vote for the questions you'd like to prioritize during the Q&A session. Okay, we are honored to have with us Dr. Diana, a specialist in anesthesiology and pain medicine with expertise in managing complex chronic pain conditions. As many of you may know, endometriosis doesn't just affect the reproductive system. It can manifest beyond the pelvis, impacting the diaphragm, lungs, bowel, bladder, and even the nervous system, leading to widespread pain that can significantly affect our quality of life. Today, Dr. Diana will be guiding us through the varied pain presentations of endometriosis beyond the pelvis, why some pain treatments work for certain individuals but not others, holistic patient-centered approaches to managing endometriosis-related pain. We will also have time for questions at the end, so do submit them through the Pigeonhole Live as the session progresses. Well, again, for those who joined us late and missed my earlier announcement, today's session will end slightly early at 1:25 as Dr. Diana has a scheduled surgery at 2 p.m. So despite this, she still chose to volunteer her time and expertise to be with us today, and we are incredibly grateful. Thank you, Dr. Diana, and the floor is now yours.
Hi, can allow me to start my video?
Dr. Diana can try share your slides.
Okay, wait now. Can I start my video? Cause it allowed it, okay. Can. Hi, okay, let me share my slides here. Okay, can everyone see my slideshow? Hi, everybody. Good afternoon. Okay, I'm Diana. Okay, so today I'm actually talking about endometriosis and chronic pain, how it impacts you beyond the pelvis and in your quality of life as well as your daily activities. Okay, so just I thank Eve for the kind introduction. So currently, I'm now practicing in the pain clinic. Previously, I was the past head of Department of Pain Medicine in SGH, and I also founded the Sing Health Duke NUS Pain Center prior to coming out to private practice. Okay, so this is actually my, just hold on. So this is actually my agenda for today. I'll first define a bit about pain and what is the pathophysiology of acute and development of progression into chronic pain, endometriosis and pelvic pain, as well as possible pain interventions for endometriosis pain and its associated conditions and impact. I'll do 2 case studies at the end of my presentations, and then I'll take questions. Okay, so interestingly, 2025 is actually identified by the International Association of the Study of Pain as the global year for women pain. We know that female pain is actually very prevalent, and we have a different physiology and constitution as compared to the population at large. And some diseases actually affect females a lot more than males. Endometriosis is one of them. And the definition of pain by the International Association for the Study of Pain is that it is an unpleasant sensory and emotional experience that is associated with actual or potential tissue damage or described in terms of such damage. So pain is not just the presence of a physical tissue damage, but there is also associated unpleasant experiences. And this is why the different women or different patients will have different pain experiences despite having the same conditions or same disease presentation. Okay, so this is a rough schematic diagram on how acute pain, on the pathophysiology of acute pain. So traditionally, I think all of us will know that when there is presence of a tissue injury or a skin injury, it results in inflammation. Our body releases substances to stimulate our nerve endings, and this transmits to our central nervous system and ascending and descending tracks to the brain to tell ourselves that we are in pain. So this is the traditional protective mechanism of pain, telling us that there is something wrong with our body. Okay. However, when pain becomes chronic, and we define that as a period of more than 3 months or so, our body undergoes certain changes in the body, and resulting such that pain itself becomes independent of even when there is whether there is pathophysiology, whether there's a pathology in our body or not. There is neuroplasticity, as what we call the nerves in our spinal cord, in our peripheral nerves, and in our brain reorganize themselves. We try the nerves reorganize themselves and result in what we call a pain experience. In certain susceptible individuals, this may result in depression and anxiety, and this may lead to certain unhelpful pain behaviors like avoiding exercises that will cause me pain, avoiding going to work, and our muscles might go into spasm to try to protect ourselves from experiencing the pain as the condition persists and as the pain persists on a long-term process. Studies have shown that on MRI, the gray matter and the white matter in our brain actually reorganizes themselves, and there is actually less gray matter in the brain, telling ourselves that we actually view pain as a different process. So this involves both a cognitive as well as an emotional organization, shaping the way how we view the chronic pain differently. So this becomes a chronic cycle of a pain cycle, which we need to break out of. Okay. So why is endometriosis such a important area and disabling area? About 10% of women actually experience endometriosis and associated pain. It is a chronic and debilitating condition that is characterized by chronic pelvic pain and infertility. So it is usually classified from stage 1 to stage 4, where stage 1 endometriosis is usually characterized by superficial lesions, while stage 4 endometriosis actually includes severe adhesions and bowel or bladder involvement. And this can result in a lot of associated symptoms, including dysuria, which is pain on passing urine, low back pain, very deep pelvic pain, sometimes pain on passing motion, rectal pain, as well, and also even joint pain and migraines and headaches. We have known that endometriosis And so this is some of the common pain presentations of endometriosis. So this urea, so if it actually impacts your bladder, you may feel pain when you urinate or generate discomfort in that area. Pelvic pain is probably the most well-known symptom, and is often described as a sharp or cramp-like pain that may hit others during your period or may not be associated with your period at all. Deep pelvic pain is usually felt deeper in the pelvic area, and you might notice it during sexual intercourse or when you have a bowel movement or even when you urinate. For chronic pain, like I've said, for pain that lasts more than 3 months, the pain then somehow doesn't correlate with your cycle anymore. It can be persistent and it can be a long-term discomfort that you realize that it's not associated with any kind of temporal changes to your body. Sometimes we might feel that the pain worsens during stressful periods, but a lot of times when pain becomes chronic, it can take a life of its own. When endometriosis actually affects deeper enough tissues or the organs that surrounds that is near to the pouch of Douglas or the uterus, it can refer the pain to your lower back and causing lower back pain. And bowel related pain if there's endometrial tissue that affects your intestines or rectum that you may actually experience during bowel movements or even when passing gas. So why is endometriosis pain so difficult to treat? Okay, so actually right now, even though there's surgical diagnosis of endometrial tissue, but we realize that the etiology and pathogenesis of endometriosis is poorly defined. And like what she said, it took her 4 years to be diagnosed. Worldwide, a lot of people with chronic pelvic pain, a lot of females with chronic pelvic pain, they take an average of about 4 to 8 years to be diagnosed with endometriosis. The gold standard of diagnosis is surgically by laparoscopy, but that would have always been some time before after a long period of chronic pelvic abdominal pain before someone decides to go for invasive surgery to diagnose endometrial tissues. In some cases, surgical removal of the endometrial lesions can be successful in relieving pain. However, there's also a lot of disconnect between the stage of diagnosis, the classification of the stage of endometriosis and surgical removal. Like, for example, someone with superficial endometrial tissue and she goes for laparoscopy and the endometrial tissue is removed. Why does the pain comes back after a few months of surgery? Why do people have to keep going in for repeated surgeries and they still cannot get pain relief? Why do people with the same type of diagnosis, endometriosis, but there are two completely different presentations? One person recovers and the other person does not recover. It's because there's a lot of disconnect and this does not correlate with the lesion score and the pain severity. Okay, chronic pain and when pain becomes chronic after 3 to 6 months, when pain takes a life of its own and our brain undergoes cortical reorganization, there's a lot of peripheral and central sensitization. Then it frequently returns even after 12 months of lesion removal and even in the absence of lesion regeneration. And therefore, we see that there is a disconnect between the traditional theory that endometriosis-associated pain, or EAP, is solely dependent on lesions. We have now cannot even find a consistent biomarker in research to prognosticate outcomes for endometriosis. We also find that endometriosis is also commonly co-diagnosed with other pain disorders, including overactive bowel syndrome, irritable bowel syndrome, overactive bladder syndrome, irritable bowel syndrome, fibromyalgia, and chronic widespread pain symptoms. There is also associated psychological disorders like depression and anxiety, which also contribute to poorer outcomes for endometriosis. Okay, so now then we look at what is complex endometriosis pain. So in the presence of all these comorbidities that I stated just now, are suggestive of a more complex pathophysiology for endometriosis. It's not just due to the presence of endometrial lesions, but the evidence actually is now pointing that there is a chronic remodeling of our nervous system, which occurs in shared sensory neural pathways to induce a state of protracted peripheral and central sensitization and chronic pain in endometriosis patients. I'll explain a bit more in my subsequent slides. Okay, so a bit back to the pathogenesis of endometriosis. Traditionally, we know that it's hormone related, and it's related to what we call a retrograde menstruation. It's estrogen dependent, and that's why some of the women, when they are first diagnosed with endometriosis, they are given medications to actually reduce the production of of estrogen, and even resulting in infertility. And we also find that endometriosis predominantly affects women of reproductive years between 15 years old to 50 years old. It is also known as a chronic inflammatory condition. Why? The presence of endometrial lesions outside of the uterus or even within the uterus release substances that we call cytokines and prostaglandins, which actually result in sensitization of our nerves, telling our nerves that there is a pathology, and the nerves send signals to our brain and our spinal cord, identifying that there is pain within the pelvic region. Then when the endometrial debris becomes ectopic, meaning that it comes out of the uterus to adhere to bowel and bladder, then there is presence of adhesions, and the adhesions result in reduced mobility of our bowels, of our bladder, and this results in even more development of lesions and discomfort with these organ functions. Subsequently, with the ongoing release of immune mediators resulting in immune dysfunction and inability to effectively clear these fragments, resulting in endometrial lesions to form in the peritoneal cavity. Okay, so this is a schematic diagram on how some of the lesions actually, how endometrial lesions are formed. Okay, so as you can see, the traditional theory of retrograde menstruation, where the blood flows backwards, and this results in immune reaction, resulting in peritoneal inflammation, causing the lesions release things like reactive oxygen species, prostaglandin E2s, cytokines and chemokines, and this results in neurogenic inflammation and sending a signal to the spinal cord, resulting in peripheral inflammation and sensitization, and eventually it activates our the brain to release mediators and tell our brain that these are areas of pain that we need to watch out for. This is called central sensitization, and this actually causes the growth of more nerve endings and more pain nerves and more pain signals that are being sent to the brain. Okay. Then as you can see, what does pain do? Pain activates the stress, cortisol, hypopituitary axis, resulting in more stress hormones being released to our bodies. It results in fibrosis and adhesions that is localized at the area where there are a lot of endometrial lesions. And because the peritoneal cavity is innervated by different types of nerves, then there's what we call cross-organ sensitization. So the nearby organs also get affected. And throughout this, when pain becomes chronic, it also affects our quality of life. Okay. And how do we diagnose? Usually, women with endometriosis first present with common symptoms like dysmenorrhea, pain during menstruation, back pain, chronic lower abdominal pain, or chronic pelvic pain. Like I said, there's no specific biomarkers identified yet, and I know that this is a very intensive area of research that our clinician scientists are looking at now. Clinical examination usually is very inconclusive. It takes a long time for someone to actually diagnose endometriosis. and non-surgical clinical examination can only correctly identify about 10% of cases, and the only definitive diagnosis is via surgical laparoscopy or laparotomy. But this is surgically invasive, and not many women will be willing to go through this. And there is also a limited understanding of endometriosis pathology, progression, and risk factors, leading often to a misdiagnosis and a consequential delay in determining the correct diagnosis. Okay, and this is a brief classification that we use medically on the stages of endometriosis, ranging from stage 1 when there's few superficial implants to stage 4 when there are many deep implants and many dense adhesions. Okay, but as I said, there's a weak correlation between the graded severity of morphological characteristics and the intensity and character of pain symptoms. And the diagnosed stage is not indicative of how much the patient suffers. The location of ectopic lesions can vary dramatically between patients and are often found in the peritoneum, but also adhered to organs like the ovaries, the vagina, the fallopian tubes, bladder, colon, and small intestine. And patients with endometriosis also exhibit significant comorbidity with chronic abdominal pain and chronic pelvic pain disorders, like I previously mentioned, painful bladder syndrome and irritable bowel syndrome. You can see that the presence of the comorbidities range from about 50% to 80%. This is why women with endometriosis have so much suffering, because it's not just one condition, but it's a few conditions associated together. Okay, again, this is a table that summarizes how it is not just the presence of the lesion alone that causes the pain, but there are so many ongoing processes resulting in a very complex mechanism that is not fully understood even now by clinicians and by scientists alone. In addition to the presence of the endometrial lesions that result in inflammation, there is also inflammation of the nerves, resulting in the buildup of a very hypersensitive environment that results in a lot of sending of our pain signals. And then this again go to the central nervous system, and I said because the nerves commonly innervate a lot of the common organs within the peritoneal cavity, the multiple organs are affected, something that we call cross-organ sensitization. Okay, so what I mean by cross-organ sensitization. So okay, you can see if you have seen a pain physician for some of your pelvic pain, sometimes you may hear some of you may have undergone sympathetic nerve blocks. It's because there are actually sympathetic nervous plexuses along the spinal cord from T10, from the thoracic level to the sacral level. And this includes splenic nerves, hypogastric nerves, plexus, and pelvic nerves, as well as pudendal nerves, and what sometimes we call, all these are lumped together, and they innervate common organs like the colon, the bladder, the uterus, the vagina. And these nerves are actually located in front of the spinal cord, the bones, and they actually send signals up to our brain when there is a affected organ. Sometimes they cannot differentiate whether it's the bladder or the uterus. It still innervates the same plexus, the same nervous plexus, and that's why when we feel the pain is sometimes viewed as a very dull ache, and I'm not very sure. Sometimes it moves here and there, but it's all within the peritoneal cavity. So what are some of the current treatments? Okay, so I think because the endometriosis presents so differently and so widely in every individual, treatments need to be individualized. And the main aim is actually to improve quality of life in these patients. In some patients, the pain may always be there, but how do we want to help the patients to actually reduce the effect of pain or the impact of pain on our daily activities? Traditionally, treatments were focused on the lesions. For example, the use of hormonal agents like GnRH agonists or oral contraceptive pills, non-steroidal anti-inflammatory drugs, and opioids But of course, with chronic use, this is also subjected to side effects, dependence, and abuse, especially with opioids. Surgical treatment, like I said, is both diagnostic and can be therapeutic. And for pain management, we want to use a combination of therapies, including biopsychosocial modalities. While we look at patients with chronic pain, we know that there is a lot of factors at place, a lot of risk factors at place. The personality, the underlying, whether there's any underlying depression, anxiety, the social economic status of the patient, as well as the family support, and also even the working environment and the stress environment that the individual is placed in. All these, we actually take a very, very holistic view on how we can individualize pain treatments for them. For pain specialist-wise, sometimes we may offer interventional pain treatments, and the list is not exhaustive, but it can include variations from ganglia impa, which is the sympathetic nerve block at the anal region, perianal region. Superior hypogastric plexus nerve blocks is more for chronic pelvic pain. Pudendal nerve blocks and peripheral nerve stimulation, and more invasive ones include spinal cord stimulators. Okay, so this is a table of some of the treatments that are currently being used. Some of you may be familiar with these and maybe still having these treatments ongoing. Okay, I will not delve into too much of this for now, but we can come back with any for Q&As. Yeah. Okay, so for pain-wise, this is an example of a superior hypogastric plexus block that I sometimes offer for patients with chronic pelvic pain, secondary to not just endometriosis, but also any pelvic congestion syndrome. Okay, so this involves 2 needles that are injected posteriorly at the back of the body across through to the front of the spinal vertebral body. This is a sympathetic nerve block, which reduces the cross-organ sensitization pain and can provide significant pain relief from chronic pelvic pain, thus improving quality of life. Okay. And this is a ganglia impa block or RFA. It is actually a small needle that is injected through the coccyx bone, which is the tailbone, just in front of the tailbone. And this is the contrast showing the needle at the right position. We inject either local anesthetic or chemical agents such as alcohol and phenol to reduce the pain from the perianal region and vaginal pain. Okay, so this is actually a recommended guideline for the setup of accredited endometriosis centers, which I'm actually hoping that it will happen in Singapore one day. Worldwide and internationally, we realize that endometriosis is a significant condition with a lot of healthcare economic burden. And there is a recommendation for the setup of a very dedicated endometriosis center with a dedicated consultant-led endometriosis service and running with a specialist outpatient clinic. Okay, there's usually a supporting surgeon who will provide diagnostic laparoscopy as well as therapeutic surgical resection of the endometrial lesions. Other supporting clinicians will usually include urologists and pain management specialists, as well as physiotherapists and a specialist nurse who will follow up closely with the endometriosis, with the patients, with the affected patients. Okay, so hopefully this will come into place one day locally. Okay. Okay, so right now I will give 2 case studies. They are all real life examples. Okay, I actually had a 40-year-old female who had chronic pelvic pain for 10 years, and she has had multiple surgeries to remove endometriotic tissues. She was diagnosed as stage 4 endometriosis, which infiltrated bladder and bowel, and is even complicated by neurogenic bladder, which means that she actually needs to put urine catheter in to drain out the urine often. Okay, she also had bowel resection due to the severe infiltration of the endometrial lesions. After her first surgery, she was actually post-operative well for 1 year, but the lesions then returned and the pain returned. She tried hormonal therapy, NSAIDs, and long-term opioids, but she also has underlying social factors, like she was depressed because of her endometriosis, and this resulted in a history of misuse and abuse and hospital admissions from overdose of opioids. Okay, she has seen many gynecologists and pain specialists. I first saw her in 2017. Okay, and she has associated comorbidities including irritable bowel syndrome, migraine, neurogenic and overactive bladder syndrome, as well as chronic back pain and fibromyalgia. Some of her social history includes like a love-hate relationship with a very controlling father, and she has no stable job. And she gets by giving ad hoc tuition to students on good seasons, but her pain has affected her and her ability to get a stable job. The good thing is that now her sister actually manages her opioid therapy, as there is an associated impulsive behavior to overdose on opioids. Okay, so we started off with a weaning opioid regimen. I told her, look, we cannot do this. We cannot always fall back on oxynorm every time your pain comes. We start you on psychotherapy on how to cope and manage your chronic pain whenever it starts, whenever you have your pain flares, and this includes cognitive behavioral therapy as well as mindfulness-based stress-based therapy, relaxation. Multidisciplinary care involved the gynae, the pain physician, a psychiatrist, and a psychologist, as well as physiotherapy to help with pelvic floor exercises. We start a bit of a reset of her resetting her pain modulating pathways by having her going through a few sessions of ketamine and lignocaine infusions. She underwent a superior hypogastric plexus block, which reduced her pain by more than 50%, which lasted for a period of about 6 months to a year. But during this period, we worked with her also psychologically, and the long-term recommendation for her is that there is always a need for her to work with the physician and be disciplined and determined, and not really just turn to opioids every time the pain comes. So presently, she's actually working in a special needs school, helping special needs kids, and she has some baseline pain, but she has no more severe attacks. She learns how to manage her mindset and break out of the pain cycle that I showed you just now. Okay, so this is one of the cases that we formed a very good long-term relationship with. She used to come in and she didn't want to talk to anyone, but I think sometimes it requires a bit of a rapport with a good physician. Okay, so this is case study 2, something less, I think a bit more cheerful. She has had chronic pelvic pain for 15 years, and she also had laparoscopic done, which was negative for endometriosis. And she was diagnosed pelvic congestion syndrome, so she had uterine vessel embolization done, and the pain improved by 50%. So not all chronic pelvic pain is due to endometriosis, but endometriosis is one of the diagnoses. Currently, she now has some residual pain in her groin and vulvar area, but it's not affecting her daily activities anymore, and it's not affecting her quality of life anymore. She underwent a ganglia impar block for her residual groin and vulvar area pain, and her pain has improved significantly with better quality of life. And the ongoing therapy was to help with her depression, with physiotherapy for pelvic floor exercises, as well as cognitive behavioral therapy. So again, I think pelvic pain and endometriosis actually presents with many different clinical presentations. Diagnosis is always difficult, and we also look at many other factors that actually contribute to the prognosis and the outcomes of pelvic pain. For example, different ethnicities, different gender identities, different physical abilities, and different fertility wishes, other associated comorbidities. We need to individualize, and then they present with many different clinical presentations. And so we need to stratify and individualize the pain treatment. And these are some of the therapies that usually we do go hand in hand and together with pharmacological, which is medications, physiotherapy, psychological therapy, plus or minus surgery, pain education on creating awareness as well as how to cope with pain, even if you don't see your pain doctor daily or frequently, but when the pain comes, how do we self cope with the pain? Having a good support network and also modification of lifestyle in terms of having a healthier lifestyle with more exercise as well as a healthier diet. Okay, so again, this is a little bit repetitive already. I just want to emphasize that not all pain is really due to the presence of tissue damage. Sometimes we actually go into a vicious cycle of pain, and pain becomes not protective anymore. And then we need to realize that we are in this vicious cycle where there is a increased perception of pain, there's activity avoidance, and very passive coping with pain. And we need to break out of this vicious cycle. And there are so many factors that will affect how you perceive pain. Biologically, maybe there's tissue damage, there is lack of sleep, there is stresses, there's dysfunctional immune responses. But psychologically, how do we cope is very important. Whether our mental health is strong enough to cope with the pain, whether there's already underlying anxiety or stress, even anticipating the pain. Like for example, sometimes when you wake up, you're asking yourself, oh, today is it going to be a good day, or am I going to feel the pain? When we start to anticipate pain, the brain tends to try to feel the pain. Actually, I feel it's not like sometimes some doctors might say it's all your mind. I don't think it's all your mind, but actually it's more of like how we have been living with this pain so much, and suddenly sometimes if we wake up and there's no pain, and then we start to anticipate the pain or be fearful of the pain. So yeah. And then our interpersonal relationships, I think having a very good support network. I think this E for endometriosis is a very good thing in that there's a support network and a support group for our patients, and also our identity and our sociological positioning, which is very important, and it all contributes to how we perceive pain. Yeah. So this is just to increase a little bit of awareness on how pain can be viewed very differently depending on where we are, on how we look at pain, or how we manage our pain. Okay, so with that, I end this presentation. And if you have anything, these are my contacts also. And I also have an Instagram that you can follow.
Thank you so much, Dr. Diana, for such an informative and eye-opening session. I think it's very relatable to most of us here. We will now take some questions submitted through the Pigeonhole Live. Okay, let's see. Okay, pain score at A&E confuses me. I'm in severe pain but tend to mask it. What is a scale meant to guide, and how can I describe my pains or limits so I'm taken seriously and get timely relief?
Okay, so pain score, if you look at, there are many different pain scales, because pain is always very subjective. It's very difficult for us to press or examine and then we diagnose as pain. But usually when we ask our patients what is your pain score, it's usually the first number that comes to mind. So you don't have to think too much. If you're in severe pain, it's severe pain. Just say pain 8 out of 10 is how much you can tolerate. Because, for example, labor pain, okay, it can be 10 out of 10 to someone, and I need an epidural in immediately. Okay, but it can to someone who has been through all these and different social upbringing, it might be like, oh, nothing, I don't feel it at all. So it's very difficult, but we want to acknowledge that this pain score is subjective and it's only dependent on you. You don't have to tell yourself that it's something that is objective. Pain is never objective, and we can never measure pain objectively. I give an example. How we ask babies or infants, how we gauge their pain, we actually gauge at how much they cry. The baby can cry a lot and we know that they are in severe pain. But different babies also different experience, right? Some babies are very stoic and they don't cry, right? So yeah, I think don't need to restrict yourself. If you're in severe pain, just tell the doctor that you're in severe pain. And usually we try not to mask, because sometimes if we feel that we can tolerate a lot of pain, like for example appendicitis, and then it's actually something that needs to be done quickly, but because you try to play down your pain, then we see it as like maybe constipation pain, and then we don't do the necessary investigations. So it's really, really, really your experience. Yeah.
Okay. The next question, can stress trigger endometriosis pain?
Okay. So it doesn't trigger the lesions per se, but I think stress actually affects how you perceive pain. So when we are in a period of extreme stress, uh, our body is in a state of a lot of stress hormones inside, and that actually sends signals to our brain to actually heighten ourselves to awareness that there's a part of us that is in pain. It's actually a body's protective mechanism to tell us that we need to slow down. Okay, for example, stress, so then you will start to be a bit more aware of your body. So these are these are biological systems that are in place that actually help us to perceive pain in a bit more intricate manner. The pain may have always been there, but sometimes when you find that you go on a holiday and then you actually don't feel the pain because you are enjoying. There's endorphins that comes from the enjoyment. Endorphins are actually opioid-like hormones that is in secreted naturally by your body. So they are actually morphines, okay? Then it by secreted naturally by your body, and that actually takes away the pain. So these are nature's natural painkillers. Whereas when you are a period of stress, these endorphins are suppressed, and then you have another group of hormones that actually heighten your perception of pain. So that's why you actually feel the pain a lot more during stressful periods.
Thank you. Okay, so the next one. Are there any ways like lifestyle changes, diet and nutrition, supplements, exercises, where you can actually help to reduce the pain and progression of endometriosis?
Okay, so there are no evidence-based uh, evidence-based or proven level 1 evidence, but in the centers that I've worked with, we've always advised on a very good good sleep hygiene, which means that you sleep enough so that your body repairs itself during sleep. Healthy diet, of course, not so much processed food. For endometriosis pain, sometimes what my previous supervisor when I was doing fellowship would do is to put them on a gluten-free diet. I don't think we need to go into such extremes because it's also very, very difficult to be completely gluten-free in Singapore. But I think more of eating organic food, eating less processed food, and a regular exercise regime will help us to actually keep our body healthy, and this overall reduces the pain and also gives us distraction, and also helps our body repairs itself faster so that the endometriosis tissue don't get has less propensity to actually be retained in the peritoneal cavity, and then our body can clear all these what we call like unwarranted lesions or undesired lesions quickly.
Okay, the next one that we have. If I am diagnosed with endometriosis with no pain, can I still conceive without the laparoscopic surgery, diagnosed through CA125 and pelvic ultrasound?
Okay, so this is very individualized. I can't say for sure, but it really depends on where is your endometrial tissue, whether it affects your ovaries, whether the sperm can actually reach the egg, and whether it affects implantation of the embryo when it's formed. So it's really very individualized and dependent, and I cannot say for sure, but definitely there will be examples of people who can still conceive without laparoscopic surgery.
All right. If hormones help pain but worsen mood or bloating, what's the point? What should I do?
Yeah. So medications wise, we all know that there is always pros and cons. It's always a balance of risks and benefits. If the hormones help to reduce the pain, but it still affects your quality of life by worsening the mood and the bloating, then we may have to look at other alternative treatments, which I've shown in my previous table. And I think it's best that you actually seek a specialist also to help to individualize your treatment plan.
All right. I'm overwhelmed managing multi-site endo. In public care, how do I coordinate gynae, GI, urology, pelvic floor, physio, and the pain clinic without a private package? Really?
Mm, I think it's very easy in public care actually. Usually the pain physician is the one that coordinates, but the referral usually comes from gynae. You don't have to coordinate yourself. Usually, I think in public care, actually, the multidisciplinary care is superior to the private sector from my experience. We all know that, our complicated endometriosis patients usually even get discussed at multidisciplinary meetings so that we have like everybody's on the same page on how we actually conduct care. So that's for public care lah. I think just a little bit to elaborate on private care is that a lot of us have our own trusted partners that we actually discuss the management plan with, and then there is easy access also to the different specialists as well as the physiotherapists. Yeah.
What role does central sensitization play in endometriosis pain, and how can it be reversed or calmed? Are there natural ways to retain my nervous system to turn down the volume of pain signals without relying on medication? And what markers or signs should I track over time to see if my nervous system is becoming less sensitized? If flare-ups happen, how can we manage pain holistically?
Okay, so this question has a lot of parts to it. Uh, Central sensitization, as I've explained just now, is that when there is actually chronic pain and our nerves actually send consistent signals to our brain actually undergoes some form of neuroplasticity or reorganization, and then we become more heightened to more pain signals, and that's how we perceive pain at a lower threshold. It can be reversed and it can be calmed, usually through a few ways. Number one is we try it without any interventions for now, including cognitive behavioral therapy, mindfulness, meditation. So this actually even on functional MRI studies actually shows that people who have pain, but if they undergo things like yoga, meditation, and even just deep breathing exercises, they actually can help to reorganize the sensitization that comes down. So it's more like not keeping ourselves in a very high, consistently anxious mode, such that our stress hormones keep getting secreted. And also, I think this is coupled with good sleep hygiene and good sleep habits. Okay, then the markers or signs. So there's no biomarkers to actually look at whether your nervous system is becoming less sensitized. It's more you look at I usually encourage some of my patients to actually keep a pain diary. What reduces the pain? What triggers the pain? How's your mood for the day? And if you find that you are always in a very bad mood, you know that you are in that whole pain cycle. But let's say if you are sleeping well and you are enjoying your activities, enjoying your hobbies, you know that you don't have to be so fixated on whether your nervous system is calmed down. And then medications, I said some things like ketamine and lignocaine infusions can help to reset the whole nervous system. But actually, everything actually takes place together. It's not like it's not mutually exclusive. The other thing would be flare-ups happen. So this is really about self-management. Some people cope with pain very well. Okay, so we don't we don't rely some people, when the pain comes, they are like, okay, let's go and do something, let's go and drink coffee, let's go and find friends and everything. But there are also people who, when the pain comes, right, they immediately say, I need to go to the hospital, I don't think I can live anymore, I am suicidal, I need an injection, I need to be admitted to the hospital, or so it's really how we cope. So there are a lot of, I think it takes a whole lecture again to go into the pain behaviors and how some pain behaviors are healthy, but some pain behaviors are actually not healthy. So it's really adopting healthy pain coping behaviors. I hope that summarizes a very, very long lecture there.
Okay, thank you. The next one. When and why will a doctor refer a patient with endometriosis to a physiotherapist?
Okay, so sometimes when there is endometriosis, there is associated pelvic floor spasms, abdominal pain, and also like I think when it's been chronic enough, and I think after the traditional medications like hormonal NSAIDs and even surgery have not helped with endometriosis, or even after surgery where there's a need to rebuild the core as well as the pelvic floor muscles, then we will refer to a physiotherapist. Physiotherapist not just treats you, helps you with exercises. I also know a physiotherapist who actually help with pain perception as well, and this actually resets the whole central sensitization again. Yeah.
Okay. The next one. For long-term chronic pain, is it possible to cope without any medication at all, such as therapy, lifestyle changes, and exercises?
Yes, it's possible. I've had patients who wean themselves off chronic pain, and they do slow lifestyle changes and exercises and distraction therapy. I think then they look at what are the things that they enjoy, and when the pain comes, they also they actually identify what reduces the pain before before really subjecting themselves to medications. Yeah.
Okay, I think I can take in one or two more questions. Do taking suitable supplements help to manage pain?
There are some supplements that I actually do prescribe to my patients. This includes vitamin Bs, vitamin D, as well as vitamin Cs, and also some amino acids, which are sometimes in the same formulation as your vitamin Bs. They may help to modulate the pain responses, or help with the nerve integrities, and help with immune system regulation. Yeah.
Okay, let's take the last question. How does nutrition help pain?
Actually, I think I answered this just now, like having a balanced diet from all food groups. Some may want to try exclusion diets like gluten-free diets. But I think most importantly is really avoiding processed foods. Yeah.
Okay, so thank you all for your participation. We have come to the end of today's session and won't be able to take any more further questions. For any additional inquiries, please feel free to contact Dr. Diana directly via the platform shared in your e-booklet. A huge thank you to Dr. Diana for her time, expertise, and for helping us to unpack the lesser known layers of endometriosis related pain. And of course, thank you to each and every one of you for showing up today, for being part of this conversation, and for choosing to empower yourselves with knowledge. If you have missed any part of today's session or would like to revisit the key takeaways, the full recording will be actually available on the E for Endometriosis YouTube channel. Feel free to share it with friends, families, or anyone who may benefit. So before we end, I'm excited to actually share that our final quarterly Zoom session of the year is happening on 13th December 2025 this year. We are honored to welcome Dr. Eleanor Low, a medical doctor who was once a patient herself. With lived experience on both sides of care, she brings a powerful and rare perspective to the conversation. Dr. Low will offer empowering insights on how patients can better advocate for themselves and seek care that honors their whole experience. This is one session you don't want to miss. Similar to today, this upcoming virtual talk is free, but registration is required as slots are limited. Registration is actually open now. You can simply scan the QR code on your screen or visit eforendometriosis.eventbrite.com. So secure your spot and let's continue breaking the silence together. Thank you once again for being here. Until next time, stay safe, stay empowered, and never stop advocating for yourself and others. Goodbye.